Hi everyone and welcome to the latest episode of Let's Talk Blood Cancer, the Patients Podcast, hosted by me, Adam Joyce, former blood cancer patient myself and patron of acute leukemia. And joining me on the sofa today, taking time out of her incredibly busy schedule, is Dr. Katharine Patrick, who is a consultant paediatric haematologist at Sheffield Children's Hospital. Katharine, thank you so much for coming to talk to us today. Let's get into talking about you as a person, first of all. Tell us about what first brought you into medicine and when you made that life choice.
As a school child, I guess as a teenager, I decided I wanted to do medicine. I don't really remember exactly what it was that drew me to it, but there's no one in my family who's medical. So, I think I really liked science at school, and I knew that I wanted a job that involved working with people and kind of that sort of human interaction. And so that's how I ended up going to medical school and becoming a doctor, but haematology was a little bit further down the line.
And when you were at medical school, were you drawn to any particular area? Was it the Gucci stuff like trauma, or was haematology actually seen as something quite exciting?
Well, haematology wasn't really on my radar as a medical student. I think it's quite a sort of small specialty and maybe something you're not so much exposed to. But I was drawn to the specialties where you kind of had patients that you got to know really well. So less so the specialties where you just see somebody once and then they're moved on to another team, and more the specialties where you have a patients that you manage for a long time and that you get to know them and their families.
That's interesting. So you wanted those almost personal interactions.
Yeah, I think so. And I probably didn't think about it in exactly that way at the time. But looking back, I think those were the specialties that I enjoyed most.
So at what point in your career did you actually then focus solely on haematology?
So the way junior doctor training works, you do a sort of general rotation and then you choose which specialty you want to go into. So at that point, I chose to do haematology. But actually, my original plan was to be an adult haematologist. And it was only later on that I kind of changed tack career-wise and went into paediatric haematology. And that was because you do 5 years of training as a haematologist, and within that training we spent 6 months doing paediatric haematology, really just to get a flavour of what haematology is like in children. But that 6 months was really transformative for me and really made me think hard about what I wanted to do in the long term. And following that placement, I then sort of changed tack a little bit and made the rest of my training revolve around paediatric haematology, and I did some extra training abroad, which allowed me then to go on and get a consultant job in paediatric haematology rather than adult haematology.
Right. Why only 6 months out of 5 years was focused on paediatrics?
Well, that's for people who are training to be adult haematologists. So you don't need, as an adult haematologist, you don't need a huge amount of experience of children, just enough to know a little bit about it, I suppose.
And Katharine, was there a defining moment for you is there something in particular that you can remember that was like the trigger for you that said, I want to work with children?
I don't think there was a single specific, I can't think of a specific moment, but over that sort of 6 month period, I think I really saw how children respond to illness, to treatment, in a different way to adults. And children they're incredibly resilient. They bounce back in a way that us as adults don't. And children get really unwell with blood cancers, with the treatment that we give them, but somehow they have this amazing ability to bounce back from that, to see the positives in everything happening. And I really enjoyed the sort of relationships that as a medical team we form with the patients themselves and the families, and we see those children all the way through their treatment journey, which for many children is a number of years. And I think that kind of interaction with the families I really liked.
And you're smiling when you say that to me about the things that you really enjoy. It can't always be enjoyment in your line of work, I guess. Do you find it emotionally challenging at times?
Yeah, for sure. And I think there are a lot of really good days at work, but there are some difficult days as well. And I think that comes as part of the job, as part of what we do. And I'm not sure that ever gets any easier, really. I think I've been a consultant for over 10 years now, and those difficult days don't really get any easier. And I think that's because we're always trying to do the very best we can for patients, for families. And I think that the way we manage that is really related to the brilliant team of people that I work with. And, it's not I might be the named consultant for a patient, but it's not really about me, it's about us as a whole team. And we have an amazing team of people in Sheffield and the same in other children's cancer hospitals across the country of specialist nurses, of nurses on the ward, of play specialists, psychologists, physiotherapists, occupational therapists. I don't want to accidentally miss anyone, but a huge team of people that are there to support the patients and the families, but we all really support each other, and that makes a big difference.
And when you first meet patients and their families, what kind of tools have you got as that named consultant? What kind of tools have you got to explain what lies ahead for these families?
I think that when you tell a family, or when a family find out that their child's got leukemia or a different blood cancer, their world, the bottom falls out of their world. And I think our job is to explain as best we can what the problem is, what that diagnosis means, what our plan for their child is, what treatment they're going to have. And we won't, at that very first day, we won't have all of the information, but we will be able to tell families this is what the leukemia is, this is what the treatment we intend to give is, and usually we talk about that sort of first few weeks of treatment with families. And there's so much information to give people, but you can't give people too much information at the beginning, because actually when you tell a family that their child has got leukemia, they actually hear very little of what you say after that. And families have told me that. They say, you told us all these things, but actually I listened to everything you said, but 2 days later I can't really remember what you said. And so I think for us, we want to give the families the information that they need. We want to make sure they really understand what's happening and what we're going to do and how we're going to try and make their child better. And for most children with leukemia, when they're first diagnosed, the long-term outlook is good. And we really try and give hope and belief to parents that, we can get their child through the tough weeks and months ahead.
And I know that there would never be a right or wrong way for a family or a patient to react. But are there some common reactions that you see?
I think people are very different in how they handle difficult news, and some people want to know everything that you can tell them about the disease and the treatment, and they want lots of information. And that's absolutely fine. We're really willing to give as much information as people want, and we can give it to them at the time that they're ready to hear it. And that might be over a number of days or weeks, or it might be right at the beginning, like people's way of coping is to get lots of information. And other people actually don't want very much information at all. What they want you to do is, you tell me what I need to do and I'll just do it. You tell me what you need to do for my child and we'll do it. We don't want too much information because that feels really overwhelming. And so I think it's about adjusting the way we talk to families based on what they need and what helps them at the time. And it's the same for children, depending on the age of the child, we would talk very differently to, a 7 or 8-year-old who needs treatment versus a 14, 15-year-old who needs treatment. And so, a lot of it is about tailoring the information that we give to families based on what they feel they need at that point. And that will change over time as well. So they may feel that they actually want not very much information at the beginning, but then a week or two down the line, they've had a lot of time to think about it, and then they do want lots of information, and we can definitely provide that.
And I really do hear you when you talk about how you must have to tailor your approach for different ages of children. But in your experience, are there any common challenges, or what are the biggest challenges for families, kind of regardless of the age of the child?
In terms of going through treatment, you mean, or first hearing about it?
Yeah, well, both really. So the challenges in them first accepting that news or hearing that news, but then about focusing on the journey ahead.
I think at the beginning, leukemia is one of those conditions that often comes on quite quickly. And a lot of the time, children haven't been unwell for months and months. They've been fine. And then over a few weeks, they've become more tired. They've bruised easily. Their parents have often felt that they're unwell, and they may have been backwards and forwards to see a number of medical professionals. And then suddenly somebody does a blood test, and then everything happens really, really quickly. They get this blood test. It's very abnormal. They get rushed to hospital. They then may be transferred to another hospital, and then suddenly they need to have bone marrow tests done. And then usually we can make the diagnosis very quickly. And then treatment starts very quickly. So there's this kind of whirlwind.
It is a whirlwind, isn't it?
Yeah, my child probably just has a viral infection to 48 hours down the line, my child's having chemotherapy. And I think that's really difficult for families.
We've had a number of guests on this show, Katharine, who have described not misdiagnosis, but perhaps it's been hard for them to get the leukemia diagnosis. So something has been wrong for a while, and there's been lots of speculation as to what might be wrong. Is that something that you see?
We do see that, and I think that's because the symptoms of leukemia are actually quite sort of non-specific in many ways. Often children are tired, they look pale, they might have a limp, they might bruise easily, they might have temperatures, and all of those things can be associated with common childhood illnesses. And I think it is right that not every child who has a temperature or is pale gets a blood test, because that would mean we were subjecting many children to blood tests. But it's in children who the symptoms are not going away. And parents know their child so much better than anybody else. And we often see that the parents say, I've known something was wrong, but it took a while to get the results. And what I always say to families in that situation is, leukemia is different to other cancers. You know, we've all heard about cancers and the importance of diagnosing cancer earlier and being able to treat cancer before it spreads to other places. But leukemia isn't really like that, because leukemia is in your blood. Your blood is everywhere. So the leukemia is already there.
Everywhere, yeah.
And it doesn't, what matters is how well the child is at the point that they present. So even if we'd found it, 2 or 3 or 4 weeks earlier, it doesn't change how likely the treatment is to work or the child's long-term chance of cure. So I try and reassure families that even though it's really awful to hear that there is something seriously wrong, particularly when as a parent you've kind of felt that but no one's listened to you, that is really difficult for them, but it doesn't change the treatment or the long-term outlook for their child.
Do you find that parents find that almost perhaps comforting, that it doesn't matter when we caught it, the fact is we know that you have leukemia now?
Sometimes people are relieved that they actually know what's wrong and that there is a plan of what we're going to do next. But I think, and I'm sure other parents would tell you this, but as parents, people often feel guilty about the fact that they didn't get this. That maybe I should have pushed the doctor harder, maybe I should have taken them into a different doctor, maybe I should have done this, maybe I should have done that. And I try and reassure them that even if we'd known a few weeks ago, it wouldn't have made a difference, as long as their child is reasonably okay at the point that they come to hospital.
And Katharine, I remember when I got my diagnosis that the burning question for me was, why has this happened to me? I'm guessing that gets asked of you all the time. And what answer do you give patients? Why has it happened to them?
So in the vast majority of children with blood cancer, it's just really bad luck. It's not anything specific that has happened. There are a small number of children who have an underlying genetic predisposition or tendency to develop cancers. And we do test for that as part of their investigations when their leukemia or their blood cancer is diagnosed. But that's the minority. And for most children who develop blood cancer as a young child, an otherwise healthy child, particularly if they've got no family history of blood cancers, then it's just extremely bad luck.
And I guess off the back of that question, do you face many misconceptions about childhood blood cancers?
I think that when you hear the word cancer, people fear the worst. They fear that it will be something that can't be treated, can't be cured. And obviously, we know, and the people listening know, that we can't cure every blood cancer in children, but the majority of children with blood cancer will be cured. And so I think there is a misconception from people who don't work in the field, who don't know so much about it, about not realising how successful our modern treatments and how successful modern day chemotherapy can be in curing children.
And how fast do you find that families and perhaps some of your older children that you treat, how fast do they learn about blood cancer? Very
fast. I think it's amazing, actually. You talk to families maybe 4 weeks down the line, they've been through the first month of treatment, and they're coming out with all these words that, 4 weeks ago they had no idea what a neutrophil was or what a Hickman line was, or all of these things that they sort of live and breathe it day in and day out. And I think for families with a child with any serious illness, but with cancer, it becomes their whole life for a period of time. And they very much become experts in the condition, in the treatment, and in their child.
And of course it becomes their whole life, as you've just said. Does it become yours as well? Or in fact, let me ask that in a different question. How do you not let it become your whole life as well? I can only try to imagine what it's like in your role. But by doing so, I imagine myself sat up in bed at 3 a.m. thinking about my patients or what I can do. How do you look after yourself?
I think it's difficult, actually. I do sometimes wake up at 3 a.m. I try not to, and I think there has to be a balance between, or a division, I suppose, between home and work, and that's a very blurry line, and sometimes I'm better at it than others, I think, if I'm honest. I think that there are difficult times at work, and there are always certain situations that perhaps play on your mind or get to you more than others, perhaps for no particular reason, but that's just, we're humans, and that's how things are. In terms of looking after myself, I think I'm really supported by the amazing people that I work with. This is not a job that any of us could do on our own, and I think the team that we work with really, really, really support each other. But then the other thing for me is really trying to have time at home with my family where I don't let those thoughts about what's going on at work kind of play into day-to-day family life at home, because then you find yourself, when you should be doing things with your own family, thinking about work, and that's hard for everyone else. So I try to separate it where possible, and I, for me personally, really find that exercise and running and now cycling really help me, just fresh air and exercise and thinking about something completely unrelated.
We've mentioned cycling, which I definitely want to talk to you about. But appreciating you can only answer as a haematologist, but would it be wrong for me to suggest that a haematologist has to have a strong emotional resilience or a different level of resilience to maybe other medical professions?
I guess every medical specialty has its own challenges. I think you do have to have some resilience, and I think, difficult situations do get to us, and not all our patients survive, and that is hard for all of us. And I think I would never want it to sound like that doesn't matter. It absolutely does. But somehow we also have to be able to come back to work the next day and to keep going for the other patients and families that are relying on the treatment that we're giving them. So I guess over time you find a way of living with that.
And I guess that's bespoke to each person in your field.
Yeah, I think it is. Yeah.
You mentioned exercise. Talk to me a little bit about exercise. So I know that you are a huge advocate for exercise of your patients as well as yourself. So let's start with the patients.
Yeah, so there's so much evidence now, increasing evidence about the benefits of exercise for both adults and children with cancer. Patients undergoing cancer treatment, and also patients who finish cancer treatment. And we know that in children particularly, so treatment for acute lymphoblastic leukemia lasts for 2 years for children. That's a really long time in your childhood for you to be having chemotherapy, to have visits backwards and forwards to hospital, and they will be at school for some of that time, but they will miss chunks of time from school. And children often, because of the side effects of treatment, become a lot less mobile. And unless you can get children back up and moving as soon as they're well enough to, it's quite easy for their peers to carry on doing exercise, getting stronger, getting faster, and children who are having cancer treatment not being able to necessarily keep up with their peers, and then they become less enthusiastic about sport and exercise, and then that can become a long-term issue for them. And there's really good evidence now that if you can keep children moving while they're in hospital, that they can get discharged from hospital sooner. So for patients having stem cell transplants, there have been some studies where they actually did very gentle exercise with half of the children during their treatment. And the children that did those gentle exercises, we're not talking about like running or star jumps or anything, we're just talking about moving around or kicking a foam ball or throwing a ball. Those children got out of hospital earlier than the children who lay in bed for the whole time. And there's evidence in adults who are having chemotherapy that if they have a sort of prescribed exercise program alongside their chemotherapy, that there's a reduced risk of some cancers coming back in the future. So there is such benefits to exercise, and I feel really passionate about trying to make that part of the treatment that we...
Do you find yourself promoting that sort of on a daily basis when you're on the ward? Are you the doctor that comes around who is insisting that the children get up and do something?
Yes. Accompanied by some of my physiotherapy colleagues who are also very on board with this. But yeah, and I talk when we're talking to patients about stem cell transplants, these children in hospital often for 6 or 8 weeks. They're in an isolation room for most of that time, and these rooms are tiny. There's a child's bed, a parent bed, and a little bit of space around them. And so I really talk to children, if they're old enough, and the parents beforehand about, even if you can just get out of bed and sit in a chair for a little bit of the day, that will make a difference. And there will be days when the child might not be well enough to do that, but on the days where they are well enough to do that, really just trying to move a little bit really helps. And we've got physios and play specialists who go in and see the children on a daily basis and we've got some like foam skittles, we've got like a foam basketballs and little things just to try and keep people moving as much as possible.
And from the perspective of chemotherapy clearly goes hand in hand with leukemia. How do you explain what chemotherapy is to young children? Have you got your own method of trying to help them understand what you as a team are going to do to them to make them better?
Yeah, and we have a team of play specialists who are really brilliant at explaining a lot of this to children. And we talk to them about, depending on their age, but we talk to them about their blood cells and have pictures of, healthy blood cells. And we show them healthy red blood cells that carry the oxygen around and healthy white blood cells that fight infection. And we talk about the bad cells that are making them feel poorly and that the medicine, we might use the word chemotherapy or we might just call it medicine, depending on the age of the child, that we're going to give them is to get rid of those bad cells and let those healthy cells get better and the strong cells get strong again. So we sort of talk about it like that. Most children have Hickman lines or Portecaths, and we usually call those wiggly lines. And so we say, we're going to give you the medicine down your wiggly line, and that's going to help get rid of those bad cells and make your good cells better again. And we try and explain it in that kind of way. You
mentioned cycling a little earlier on, and that you are cycling. Not just a little bit of cycling on a Sunday, isn't that right? What are you up to, Katharine?
So I am cycling the route, which is a cure leukemia event, cycling the route of the Tour de France Femme, which is the women's Tour de France. So Cure Leukemia are organising a group of female cyclists to ride this event one day ahead of the race. It starts at the end of July in Switzerland and then goes down through France and finishes in Nice over 9 days.
It's going to be absolutely incredible. And I'm really hopeful that I'm going to be out there on the finish line as well for when you get there. Cure Leukemia's CEO, James McLaughlin, had something to do with you taking on this event, didn't he?
Well, sort of. So last September, I think it was, James was doing Run the Nations, where he does this incredible run between all of the hospitals treating blood cancer in the UK. And he was in Sheffield for the day. And so I ran the Sheffield leg of his run with him, with a few of my colleagues and a patient's mum, Jo, who was on this podcast before. But in the run-up to that, I'd been sort of looking on the Cure Leukemia website and I saw about the route, and there was just something at the back of my mind that was, that would be really good. And Rob Wynne, who's a paediatric haematologist in Manchester, had done the Tour 21, which is the 3-week men's Tour de France route a few years before.
Broke his arm doing that as well.
He was incredible, and I heard all about it and thought, wow, that is amazing, but I could never do that. But then when I was like, well, 9 days, that maybe I could do that. And I have cycled a fair bit in the past, but never anything like this. Never sort of seriously or competitively or with a club or anything, just for fun, really. And then I sort of mentioned it to James, thinking he might be like, no, we're only after really super hardcore, serious cyclists, not you. But he didn't say that. He was really enthusiastic about it, actually, and he put me in touch with some people who did it last year, and they were also really enthusiastic. And then I thought, I'll never be able to get that much time off work. Yeah. And then they were like, yeah, no, that's a great idea. And then I thought, my husband's going to think this is a terrible idea. And he's like, well, that sounds amazing, you should do that. So
it sounds to me like you were looking for every avenue out, but all these doors were opening.
Well, sort of, although I think deep down I wanted to do it, or else I wouldn't have really thought about it. But I kept thinking, there must be a reason why this is a crazy idea. Someone soon is going to tell me this is a ridiculous idea, don't be so silly. But then everyone just kept saying, yeah, you should go for it. So. And
how do you feel about it now that it's so soon?
Terrified. Excited as well, like really excited. There's such a lovely group of people doing it. I've met some of them, and we've got a sort of active WhatsApp group. Everyone's updating each other about what they're up to and training, and so it's really exciting to be part of it, but it's also quite terrifying.
And just like everybody else who is taking part in this challenge, you have to raise a big amount of money. How are you doing on your fundraising, and what kind of ideas have you had? Yeah,
so getting there, thanks to a lot of support and generosity of friends and families and patients and their families. So we've done various things, actually. Some local things at home through my own friends and family. One of my old school friends, actually, her daughter, who's 15, organised a non-uniform day at the school she goes to is my old school. So and they raised nearly £900.
Amazing.
So they did a big non-uniform day. And then we've been doing some sports-related things, and we have a big activities day once a year for all the children who've had cancer treatment or a stem cell transplant at Sheffield Children's Hospital, called the Do It For You Day. And that was back in November of last year. And one of my colleagues and I took our bikes on the turbo trainers, linked them up to Zwift, and then we took 3 other smaller bikes, kids' bikes of various sizes, and linked them up to Zwift as well. So we had 5 bikes all linked up. And then so Dan and I rode for all of the day, and then we just swapped children on and off the bikes for the whole day. So that was brilliant. And, lots of people listening might know about Zwift, but for people who don't, it's a sort of virtual reality cycling thing. So you watch on the screen, and as you pedal, you move along. And we had them cycling like around the sea, through the volcano, and it was brilliant. And that was it. It was a good day.
You said that lots of your patients and fellow colleagues at work have been really generous in supporting you. Are you telling everybody that you can possibly tell that you're taking this on?
I think I probably should be. I don't think it's my natural thing to sort of, this whole self-promotion thing I find a bit uncomfortable, actually. And this has sort of pushed me out of my comfort zone in telling people what I'm doing. But yeah, a lot of people do know. And then the word has definitely spread, because there's some lovely donations and comments on the Just Giving page from patients that I haven't seen, that have finished treatment, I haven't seen for quite a while. So they're obviously finding out through other people. So, yeah.
Of course, Katharine, there's a whole different take on fundraising. So Cure Leukaemia, we are fundraising, and we are taking you out of clinic and putting you on a bicycle to raise all of this money alongside other fantastic fundraisers. But we are trying to raise money to support you to do your job. How do you feel about that? And I don't mean about the generosity of the charity, but I guess the question I want to ask you is it right? Should it even be this way?
It would be brilliant, wouldn't it, if we could fund all the work that we want to do without people having to, cycle through France or, fundraise. But I think, that's where we are at the moment. Our hope is that we can get the Atticus network up and running, and that the funding the money that we raise through Cure Leukaemia can fund the startup of the Atticus network, and that will then, in time, bring in money through clinical trials, and so hopefully it will be able to sort of fund itself moving forward. But at the moment, there are so many people out there raising money, doing incredible sporting events with Cure Leukaemia to raise money for the Atticus network.
It is incredible. And you've mentioned Atticus. Why is Atticus so important?
So Atticus is a clinical trials network for children for clinical trials for children having stem cell transplants. And there's a really successful model of this in the adult world, and they've been hugely successful in bringing clinical trials to patients. What we hope Atticus will do is allow us to open clinical trials across all of the stem cell transplant centres in the UK and bring drugs which we know and believe are likely to be effective for children with blood cancer directly to patients. At the moment, there are lots of drugs that are proven to be effective in adults, that are likely to be effective in children, but we don't currently have access to those drugs. And that's because it hasn't been proven in studies that they are both effective and safe in children, and we won't be able to get access to them until we can demonstrate that. So we would really like to run those trials, but to do so requires a lot of funding, and people listening may not really understand why that is, but the drugs themselves may be expensive, but when you're doing clinical trials and you're testing new treatments on children, it's really important that that's done ethically and appropriately, and to do that requires a lot of collection of information. Making sure that the right patients are on the study, collecting all the follow-up information about how well they respond, what side effects they get, so that we can really further down the line show whether that treatment was effective, and if it was effective, how effective, and prove that it's safe in children. And once that's happened, then that treatment can be used, in a more widespread way.
It sounds that the vast majority, and please correct me if I need to be corrected, that it's about the logistics, it's about the organisation, because there's lots of pockets of incredible work happening, but it's never been coordinated in such a way.
Yeah, that's right. And I think if you if you're a drug company and you have a drug that you want to trial in children, then at the moment, if you want to open it in enough hospitals to get results from enough children, you have to go around all the different hospitals and open it in all of those different hospitals. It's hugely time consuming and very expensive for drug companies. And so it's not a very appealing option for them. Whereas actually, if we had the Atticus network set up, the company could come to Atticus and say, we would like to test this drug. And then the Atticus framework would be set up. We would have research nurses, data managers in each of the centres, and that trial could then be rolled out much quicker.
So we're making it easier for the big companies to do what they want to do.
We are, yeah, exactly. And also we're providing a structure for, there are other trials that we would like to do that perhaps won't be supported by big drug companies because there isn't a specific drug that they want to look at. But there are other things that we as a community believe would be really effective. And so without the support of big pharma companies, then you need another way to be able to do these trials. And one of the things that I think is really important, we talk a lot about treatments for blood cancer and new treatments for leukemia, but actually one of the other really important areas is around supportive care, and that means dealing with the side effects and complications of treatment. And particularly in children having stem cell transplants, we know that children can develop really life-threatening complications, can die from complications of the transplant, not because the leukemia comes back, but because they develop a side effect that the treatments we have at the moment are not effective for. And that's another area that as a community we really want to work on. And that might be treatment for certain infections. It might be treatments for certain conditions that can happen after transplants and affect your vital organs. But some of those conditions are also really vital in saving children's lives.
And Katharine, as a consultant haematologist now, really well into your career, if you look back at yourself as maybe a med student or when you first started out, what would you say to yourself?
I think that, our careers, for all of us, whatever we do, are long, hopefully, 30 plus years. And I think that whatever you decide to do has to be something that you really enjoy. Somebody once said to me that really interesting bits of medicine are interesting whatever specialty you do. What you need to do is choose a specialty where the day-to-day bread and butter work of what you do you really enjoy. And I think that sometimes it might on paper look like a more difficult career. It might have more on calls or more, whatever, shift patterns or whatever it is that you think, I don't know if that's the right thing. But if you really love it and it's what you know that you're going to enjoy doing long term, then I think you should go for it, because I feel very privileged actually to have a job that I really enjoy doing. There are many people who get out of bed in the morning and think, oh God, I've got to go to work. And, I don't get me wrong, it's hard at times, but I feel very lucky to have a job that I, enjoy as much as I do, and that I can go home at the end of the day or the end of the week and feel like, what we've done as a team has made a difference to people.
It was the right choice for you, wasn't it?
Yeah, I think it was.
We know that people find our podcast for lots of different reasons, but one of those reasons is that they are newly diagnosed, or they are the families of newly diagnosed patients, and they come to our podcast looking for advice, for support. As an expert, what could you say to people who are watching this now and they're at the start of their blood cancer journey?
I think that for most people, that beginning stage is really difficult, because suddenly your whole world is turned upside down, and all the things that you thought were certain are no longer certain. You can't plan anything. People previously would have been like, right, in this summer holiday I'm going to do this, and this weekend I'm going to do this, and suddenly you can't do any of those things because you don't know when your child's going to need treatment, you don't know when they're going to be poorly, when they're going to be in hospital. So I would encourage people really to take it day by day and week by week. We are so fortunate in the UK that there are amazing hospitals around the country treating children with blood cancer. And as a country, we have a network where every child with leukemia in the UK is treated in exactly the same way wherever they're treated. So I would reassure people that they're in very good hands. And I would really encourage them to ask their team if they've got questions. And sometimes people worry about asking questions. Are they going to think I'm silly? This is a daft question. But there's no such thing as a silly or a stupid question. If it's something that you're worried about, I'd really encourage you to talk to the team looking after your child, explain what it is and ask them, and I'm sure they'll do their best to answer. And then finally, I would caution people a little bit about Googling too much.
Yes. We hear that on here.
There's so much information on the internet, and there is some brilliant information on websites like Blood Cancer UK and CCLG that's got loads of really good information for patients and families. But there is also a whole minefield of other information, and one child's leukemia could be hugely different to another child. So I would just caution people against too much Google searching.
Thank you. And this may seem like a ridiculous question, but how do you feel when patients who were very ill come back to see you and they look wonderful, and maybe they are at their last few blood tests before they are told they don't need to come back to hospital anymore? They're at the end of their journey.
I mean, I guess that's probably why all of us do it. And yeah, I think it's amazing, actually. And particularly those children who have been really unwell. We've got children who've been in hospital. Some patients were in hospital for 6-9 months and they were so poorly during that time. And you know how hard it was for them and their families. And then you see them, further down the line, and they're back at school. They come into clinic in their school uniform, or they're back doing all their sort of normal stuff. And yeah, it's really, really lovely to see.
Good. Well, on that really positive note, I want to thank you so much for coming into the podcast today. A massive good luck for the ride. Stay on the bike.
Thank you.
Because we definitely need you back working straight afterwards. Thank you so much once again. And for everybody watching, Dr. Katharine Patrick, and we'll see you on the next episode.